Hi, good evening. My name is Dr. Nicholas Sablan, and I'm going to be talking to you today from Tidewater Orthopedics office in Hampton, Virginia about rotator cuff injuries. This is a brief bio of my timeline and training, to include travels all the way from Connecticut, New York, California, and over here to Tidewater, Virginia. I've been here since 2011. I have a special focus on sports medicine injuries and a particular focus on the shoulder. And as you can see, the shoulder, elbow, and knee are my primary area of focus, and we'll go over and focus mostly on the shoulder today, but open the questions up. So, tell you a little bit about Tidewater Orthopedics. There's 10 orthopedic surgeons, 6 physician assistants that assist us both in everything from seeing patients in the office to assisting in surgery. We have a subspecialty practice model, and that's a confusing comment for a lot of people, but what that means is that each of us specialize in a certain area of expertise within orthopedics, be it total joint replacement, sports medicine, hand surgery, foot and ankle surgery, neck and back surgery, as well as joint replacement surgery. We operate exclusively at Centera facilities. My primary area of surgery is at the Careplex Ambulatory Orthopedic Surgery Center at Centera Careplex, because I predominantly do outpatient surgery. But I also operate at Centera Careplex Hospital in Hampton, Virginia, as well as Centera Williamsburg Hospital in Williamsburg. Here's our 3 locations. I currently see patients in our Hampton as well as Williamsburg office, but we opened up a relatively new office in the Suffolk office in Suffolk, Virginia, that we're excited to see new patients and are offering the same subspecialized model there. Here's some of the services we provide, including our orthopedic clinic. We have in-house x-ray as well as MRIs. We have our own in-house physical therapy as well as occupational therapy, including certified hand therapy. This is a little bit about our Careplex Ambulatory Orthopedic Surgery Center, where I do the majority of my surgeries at. It was opened in 2010. It's a large state-of-the-art facility that focuses exclusively on the care of orthopedic patients, and specifically at Tidewater Orthopedics. It really allows us to kind of move that subspecialty model to all the technicians and help that we get in it. So it really provides really cutting-edge orthopedic care in Hampton Roads. Now I'll talk a little bit about shoulder pain and rotator cuff problems. A little bit about the anatomy. The rotator cuff, I get asked a lot of questions about it. There's 4 major tendons that make up the rotator cuff. There's a muscle that attaches to a tendon, and the tendon attaches onto the bone. So it's a cuff of tissue that involves with basic activities, including moving the arm and using it. Characteristic symptoms that you see is pain over the lateral aspect of the shoulder. The primary complaint that I get in the office is they'll have pain with overhead activities, and pain at night are really the classic symptoms that you'll see with rotator cuff problems. Usually there's not a major trauma on these things. A lot of people like to associate rotator cuff injuries with some specific trauma, but usually it's a gradual repetitive activities. As you can see up here, nighttime pain. And when people ask, when do I need to come and see an orthopedic surgeon? What I always tell patients is that common sense, rest, anti-inflammatories. If you're still having pain after several weeks and it's affecting your quality of life, whether it be difficulty sleeping or difficulty with activities, whether it be work-related or activity-related, I think that's a pretty good common sense answer for everybody. I kind of jumped to the conclusion on surgery, because that's what we're here to talk about, but it's not exclusively. We always try to exhaust all non-operative measures here at Tidewater Orthopedics, and the shoulders in particular. If you see up here, there are a lot of asymptomatic patients out there with rotator cuff problems that we would not recommend fixing at all. The decision to fix is really a shared decision-making process that goes in, that discusses the activity of the patient, the age of the patient, and really the goals of what they're trying to accomplish, and how much dysfunction and how much of their shoulder symptoms are affecting their quality of life. Who definitely needs surgery? It's the patients with large tears that are not responding to the simple activities of simple conservative measures, whether it be a steroid injection, physical therapy, anti-inflammatories, and they're having pain that's either, again, affecting their work ability, their ability to sleep, or goals that they have, whether it be to return to recreational tennis, swimming, etc. And a question I get asked all the time is, can you wait too long? And unfortunately, the answer is yes. If you look at any other muscle, this whole idea of move it or lose it applies to rotator cuff issues. So you can wait too long, and when that happens, the muscle starts to turn, the muscle cells start to turn into fatty cells, and the muscles start to atrophy. And some of that is going to be irreparable, meaning that it's going to get to a point where you can't convert that fatty tissue back to muscle. And unfortunately, the longer you wait, the larger the tear becomes and the more atrophy that occurs. Thankfully, that does not happen over days or weeks. We're talking months to years for the majority of rotator cuff problems. So it's not something that you have to run in emergently and get fixed, but it's something that you really want to be conscious of as you're going through this decision-making tree. Who's at risk? I mean, I go through the laundry list, but it's really an age-related phenomenon with regards to rotator cuff problems. Some overhead athletes, weightlifters have a proclivity for rotator cuff issues, but really the age of the patient is probably the primary determinant on the size of the tear and whether or not they have a full tear of the rotator cuff. Some of the risk factors we talk about, a commonly thought process is that bone spurs were the precipitating event that caused it, and it may or may not have some role in it, but it's probably not the primary issue at hand. Most of this is a degenerative process that's going on over time with repetitive activities, and we look at microscope slides, which really have shown this. Another thing to talk about is referred pain, because every day in the office I see people with neck issues that are really mimicking shoulder issues, and a good thorough physical examination will help to decide whether your primary source of your shoulder problem is coming from your neck or your shoulder, or some of these other listed problems, which are much less common. Thoracic outlet syndrome being a nerve-related problem that I see more commonly in either traumatic injuries or young athletic overhead laborers. I've harped on this a few times already, but I'll just mention again, age does matter with regards to rotator cuff problems. If you look through some of the data and the prevalence of rotator cuff tears, you see that it really increases as we get older, with the incidence of rotator cuff tears clearly following along a temporal association with age. I go over this again, and I can't say it enough. A good thorough cervical or neck exam is really important to rule out, because if you look at the mimickers of rotator cuff problems, the neck is by far the most common issue that you'll see some confusion in with regards to what is it, the neck or the shoulder. In my younger patients, classically under the age of 40, a lot of these shoulder-related problems can be related to dysfunction in the scapula or wing bone in terms of how it moves and how it functions, and it can mimic impingement of the shoulder, not caused by bone spurs or by repetitive activities, but more because there's less space for the shoulder girdle and the rotator cuff to travel, because the scapula, which is really gives you the platform of the ball and socket joint, causes some dysfunction in its positioning. Our physical examination is fairly straightforward with regards to orthopedic examination. You always look at somebody. I always like to see if there's any evidence of atrophy, if there's any guarding that's going on in the arm. And another common exam that I look through is range of motion, specifically passive motion, how much I can move them, because that will help me differentiate a rotator cuff problem versus another common problem I see in the shoulder, frozen shoulder or adhesive capsulitis. A few of the tests that we'll run through quickly. This is looking at the four major rotator cuff muscles. You have your supraspinatus, which tests the arm in above shoulder level, your infraspinatus, which really tests your rotational strength, your subscapularis, which tests your internal rotation strength, and your teres minor, which is thankfully a very uncommon injury of the rotator cuff, which tests your resisted rotation when your arm is in what we call an abducted or lifted position. We always start in the office. I get a lot of questions about why do we get x-rays. They won't show anything with the rotator cuff, and although that's true, you can see a lot of things. Every day in the clinic I'm seeing people with calcific tendonitis, which are little calcium deposits that show in the rotator cuff. I can evaluate for arthritis in the shoulder. You can see, rarely thankfully, tumors that are present within the arm, and it allows me to rule out a lot of other potential causes of shoulder pain. One of the things that I do look at is the shape of the acromion, which is a continuation of the scapula, which it was felt to, these bone spurs were felt to be the primary source of rotator cuff problems. That's largely been debunked, but it does appear to be a contributing factor, so it's still something that we look at. And then, I'll kind of skip around to rotator cuff problems and can they heal on their own? It's a very common question I get. Unfortunately, full thickness tears of the rotator cuff do not heal on their own. They tend to get larger. The muscles tend to atrophy. Again, thankfully, that problem is something that does not happen emergently. It's not something that happens over days or weeks. For most rotator cuff issues outside of trauma, it happens over months to years. So there's a chance to be able to exhaust all conservative measures. Although, again, one of the fears we have is that over time, some tears can reach the point where they can't be repaired, where the ability to be able to repair the rotator cuff is impossible, and you start to look at other less satisfactory options, which I'll run through. And as you run through this, probably the most common issue we get to is once you have a rotator cuff tear that's been present for many years and the ball no longer is traveling squarely within the socket but is actually riding up, unfortunately, your options do not include repairing the rotator cuff any longer, and you start talking about other options such as shoulder replacement, and specifically reverse shoulder replacement, which is a great option and works very well for the vast majority of patients, but is clearly more invasive than a standard arthroscopic rotator cuff repair. Our non-operative measures that we talk about include simple measures like anti-inflammatories, physical therapy. There's some confusion and questions with regards to the role of steroid injections in the treatment for rotator cuff problems. They clearly do not have a role in the healing process, but for a lot of patients whose surgery is a last option, they can provide fairly significant pain relief. The imaging modalities that we use over here at Tidewater Orthopedics include an in-house MRI and an in-house ultrasound machine. MRI is a much more sensitive and specific tool to be able to evaluate the rotator cuff, but ultrasounds are great options that we have available to us if a patient can have an MRI for some reason, whether they have a pacemaker or some other contraindication to an MRI, including severe claustrophobia. It can at least give me a ballpark idea as to what the status of the rotator cuff is, but MRI being the workhorse for the diagnosis of rotator cuff tears. This is an example of a rotator cuff tear where you see the tendon edge coming up right here to the middle aspect of the humeral head, and you see this discontinuity of the tendon as it tries to attach on. You still see a stump left over of the rotator cuff. And then who does worse with non-operative management? I think a lot of these answers are self-explanatory if you listen to the talk. Larger tears, unfortunately, are more painful and cause more dysfunction. People with symptoms that have been present for a longer period of time typically don't do great with non-operative management. And also patients with significant pain and weakness have been shown to have larger tears than patients with smaller tears. And when you talk about the operative treatment of rotator cuff tears, they can range from a simple cleanup. That is usually deferred to patients who are of older age and have lower function, and they may not want to go through the rehabilitation process associated with rotator cuff repair. You can just clean up the bone spurs and create more room for the rotator cuff, or you can do what's most commonly done for full thickness tears, which is to repair the rotator cuff. And here's some nice things to take home with regard to when is surgery necessary. Reasonable to treat patients with full thickness rotator cuff tears or high grade partial tears if they failed conservative measures, which can range from 6 weeks to 3 months. Trying your anti-inflammatories, trying your physical therapy, recognizing that there's that trade-off of giving time for symptomatic improvement versus delaying care so much that the tear optimization becomes compromised and the likelihood of success goes down. This is some of the basics. We're improving the amount of space for the rotator cuff to avoid that impingement. Again, we don't think that that's the primary issue at hand. Here's an example of a rotator cuff. Here's its tear where it's supposed to be attached down to here. We're cleaning up the bone spurs. This is the more classic treatment where we actually did that with an open procedure. Thankfully, that is not how we do it now. Now, all my surgeries for rotator cuff repairs are done arthroscopically through little pinholes. This is that most classical treatment. It's still done fairly commonly in the United States, but becoming increasingly less common, where surgeons have to detach a portion of the deltoid and make a rather large incision to be able to repair this. It's unfortunately associated with higher stiffness rates and also more morbidity, meaning more pain, especially if you can accomplish these similar goals through less invasive means. And if you look through, again, this is what arthroscopic surgery looks like. You've magnified the rotator cuff. Here's the ball of the humeral head, and then this is the socket, and here's the attachment of the rotator cuff as we look through here. And after we repair it, and there's a variety of means, the most common one used now is called a double row technique, and it's beyond the scope of this talk, but what we're doing is multiple sutures being passed through the rotator cuff and attaching it through 2 layers to provide additional biomechanical security, which increases the healing rate of rotator cuff tears. And the keys to success, we talk about this, is giving up enough room for the rotator cuff to be able to travel, getting a tension-free repair through different tricks that we can do to be able to diminish the amount of scarring that's present, get a secure repair. That's why we're using multiple sutures, multiple anchors to repair this over a large surface area. And you need to protect this. One of the issues with rotator cuff surgery is the extended rehabilitation process, but it's really critical, and it's probably the most important part of this whole process if you want to have a successful outcome. And you look at the prognostic factors that have been shown in surgical repair of rotator cuffs. The size of the tear, smaller tears do better than larger. The age of the patient, the younger you are, the higher the healing potential that exists. The amount of fatty degradation, which has to do with the length of the tear and how long it's been present. And then having, which has been shown, and the reason why we go to this subspecialty model here at Tidewater Orthopedics, having somebody who specializes in any treatment gets better outcomes because they have a higher volume of surgery. And so in conclusion, rotator cuff tears become increasingly common as we age, and with patients leading increasingly active lifestyles, it's really not a great option for non-operative care in those patients who want to maintain an active lifestyle or having simple, pain with basic activities such as sleeping and overhead activities. But not all rotator cuff tears need to have surgery, and I think I've gone through a little bit of the options that exist for patients without surgery. Arthroscopic surgery, which is the tiny poke holes that we do here at Tidewater Orthopedics, have become the most common way to treat rotator cuff surgery problems. And with proper indications and techniques, it's become an increasingly higher and higher successfully operation. So now we'll turn it up to questions for anybody.
So, our first question rolled in. So if someone has a torn rotator cuff, would that contribute to their shoulder dislocating more often with movement?
So the question was, will a torn rotator cuff increase the probability or likelihood of the shoulder dislocating with movement? And thankfully, dislocating shoulders are typically a problem of younger individuals that have other issues and other pieces of cartilage called the labrum. But the rotator cuff is a secondary and a dynamic stabilizer of the shoulder. And unfortunately, with people who dislocate their shoulder in older age, they can have torn rotator cuffs being the most common sequela of the dislocated shoulder. So not a classic symptom, shoulder dislocations, but can be, it is a stabilizer of the shoulder and does provide some of that congruity and stabilization of the ball and socket joint.
Another question came in was roughly how many months or years before a tear can be assumed to be irreparable?
Different for every patient. I will tell you, even within the rotator cuff, the most common tear that we see is the supraspinatus, which is that tendon that's on the top part of the rotator cuff. I've seen it go years and have MRIs 4 or 5 years in between where the tear size and degeneration has largely been unchanged. The front muscle called the subscapularis, I've seen that change and become atrophied in the matter of weeks to really more like short months. And so it depends on, there's a lot of variables that we don't have clear answers on that. And a lot of it depends, one of the biggest tip-offs as to whether the tear is degenerating or getting larger is the dysfunction and pain. So if you use some of those subjective complaints that the patient has access to, largely speaking, if your shoulder pain is increasing and your dysfunction is increasing, there's a good chance that your tear is getting larger and the muscles are starting to degenerate.
Another question is, can you have rotator cuff issues without scapular winging?
So can you have rotator cuff issues without scapular winging? And most definitely. The scapular winging issue is more an issue in some of my younger individuals, so under the age of 40 classically, but it can involve all age groups. But I would say the majority of my patients who have rotator cuff problems do not have scapular winging issues.
Can you get a tear on the same shoulder that has already had a separate tear repaired?
So the question is, can you get a re-tear of a rotator cuff tendon that's already been fixed? And unfortunately, that answer is definitely yes, especially when you start to look at these larger tears, or what we call massive tears, where they involve either multiple tendons within the rotator cuff or the size of them increases more than 5 centimeters. The tear rate can be very high, and upwards of 50%. The smaller the tear, the lower the re-tear rate, where you run more in the 5 to 10%. And there's a difference between tearing your rotator cuff again and having symptoms again. It's not uncommon after rotator cuff surgery to have partial tears present, but it's less common, thankfully, that they have full tears. But it unfortunately is definitely an issue, and again has to do with age and the size of the tear and the rehabilitation process.
Another question is, what is the average time for recovery?
So the question is, what is the average time for recovery? And it does vary, but generically speaking, if you have an average size rotator cuff tear, you're in a sling for somewhere between 4 to 6 weeks. The recovery of range of motion typically takes about 3 months, and it takes about 4 to 6 months to regain full function of the arm.
Does the surgery help a senior be able to hold their arms up to fix their hair, for example?
So the question is, does the surgery help a senior be able to lift their arm up to do basic daily activities like fixing their hair? And the answer, thankfully, is yes, for the vast majority of cases. Obviously, there are exceptions to that rule if the tear has become very large or irreparable. Unfortunately, the older we get, the healing potential goes down, and so we can modify that with the number of sutures we use, as well as the rehabilitation process, to give the vast majority of patients with activities of daily living or ADL goals to be very functional.
Roughly how long after surgery would you be able to play a sport again, like tennis, for example?
So for an average the question is, how long after surgery would you be able to return to an overhead activity such as tennis? And I said it would vary again based on the size of the tear, but generically speaking, for golf and tennis, I let patients start to do some activities at 3 months, especially lower head, whether it be doing their ground strokes or whether it's chipping and putting for golf, and to resume full activities, serving or overheads for tennis, or to have a full swing with a driver in golf. That number again ranges from somewhere between 4 to 6 months, depending on the size of the tear and the quality of the repair.
Are there any restrictions following surgery, such as work or anything else at home?
So the question, are there any restrictions following surgery? And I think we've talked about those restrictions that can exist between the first 4 to 6 months. But if the question extends beyond that, I allow patients after 6 months or 4 months, depending on when we have proof that the tear is healed, to let them resume all activities as tolerated, to return back to their active lifestyle, whether it be at work or recreational activities.
Where do you perform the surgery?
The question is, where do I perform the surgery? And I perform the majority of my surgeries over at the Careplex Ambulatory Orthopedic Surgery Center in Hampton, which is adjacent to Centera Careplex. But I also have operating privileges and do certain shoulder surgeries both at Centera Careplex Hospital in Hampton as well as Centera Williamsburg Hospital.
If someone has already had shoulder surgery done, they put in parentheses, not by you awesome guys, but is still experiencing pain and limited movement, would you recommend them to come see you?
So the question is, if somebody's already had shoulder surgery by an outside place and they're still having persistent issues, would they recommend me seeing them? And the answer is absolutely. We don't it's nothing wrong with the surgery that they had done elsewhere. Not everybody gets optimal outcomes, myself included. And it's good to have a thorough evaluation and sometimes a second pair of eyes to be able to look at this. And I'd absolutely, be honored to see and at least give my input and recommendations for those patients.
Another question, do you do reverse shoulder replacement and can it be done outpatient?
So the question is, do I do reverse shoulder replacements and can they be done outpatient? And the answer is yes. I do many reverse shoulder replacements a year, over 30 a year. And do I do them as an outpatient? And that answer is yes. Between COVID and kind of a natural patient selection, we've learned that there is rarely an operation from a shoulder standpoint that needs to be done as an inpatient, that I would say the vast majority of my reverse shoulder replacements go home that same day, unless there's some social issue or medical issue that would preclude that.
How do you decide between an arthroscopic repair versus an open repair?
So the question is, how do I decide between an arthroscopic and open shoulder repair? And I can tell you in my hands, doing close to 700 arthroscopic surgeries a year, that I have not converted to an open rotator cuff repair in many years, because the skills that we have, that we've developed over time, and also the tools that we have available to us, has really negated the need for open rotator cuff repair.
So, do you have experience with patients who have had hypermobile Ehlers-Danlos syndrome with lax ligaments and thin or fragile skin?
So the question is, do I have experience with patients with collagen disorders such as Ehlers-Danlos and other issues in fragile skin? And that answer is yes. It's a difficult group because their collagen gives them a proclivity to stretch out again. Not as substantial for rotator cuff tears, but some other issues within the shoulder, such as the labrum and the capsule. And so we have ways to be able to modify that, but for the majority of patients with collagen disorders, we try to exhaust all conservative measures to include therapy to strengthen muscles like the rotator cuff to be able to provide some stability to their joints.
If I just got a steroid shot in my shoulder, can I still have surgery?
So the question is, if I just got a steroid injection in my shoulder, can I still have surgery? And the answer is yes, but with some qualifiers. There's more and more data out there with regards to what steroid injections do. They may inhibit the healing process up to a year after injection and before surgery. And so it's a shared decision-making process. On one hand, we recognize the limited goals of steroid injections. At the same time, we also recognize that we don't want to rush everybody off to surgery, and that steroid injections are a great part of our arsenal to be able to provide appropriate non-operative care for patients with shoulder issues.
If I have an average job, for example, an office or computer position, roughly how long would it be after surgery before I could return to work?
So the question was, if I have an average job, i.e. an office-based job, how long would it be before I'm able to return to work? And again, that's a shared decision-making process. If your goals are just to be able to type, write, and answer a phone, I have patients able to do that within a week. Most patients are experiencing pretty significant discomfort for the first week or two after surgery. So a lot of it depends on what other goals they have to do. Do they have to drive themselves to work? Do they have alternative means of transportation? Do they have to do anything besides basic typing, writing, and such? But if you ask the question, when's the earliest somebody can go to work? I've had people return to work on Monday after a Friday rotator cuff surgery if they have a primarily office-based job.
If I have a torn rotator cuff on one side, does that mean the other side will also eventually tear?
So the question was, if I have a torn rotator cuff on one side, does that mean that I'm going to have a rotator cuff tear on the other side? And the answer is mixed. If you look at studies that are out there, primarily done with ultrasounds, we see that once you have a tear of one shoulder, the likelihood is significantly increased compared to the average person of having a tear in the other shoulder. That being said, not everybody with a rotator cuff tear becomes symptomatic. Either they have a smaller tear that other muscle groups are able to make up for and compensate for, or they modify their activities. So the short answer is yes, but there's more to it.
How many injections do you do before going into surgery, if needed?
So the question is, how many injections do I do before surgery? And really that's a shared decision-making model. If I have a younger patient with a traumatic injury, I'm not doing any injections before proceeding with surgery if they have a full thickness tear of their rotator cuff. If I have an older individual who has maybe more simplified activity goals, I may offer multiple injections beforehand, understanding that with each injection we may be compromising the healing potential of the rotator cuff, but also recognizing that not every patient is interested in going through the rehabilitation process associated with rotator cuff surgery.
I believe you mentioned this one earlier, but somebody asked for a refresher. How long following surgery do you restrict active range of motion?
So the question was, how long do we restrict active range of motion after surgery? And just to clarify again, active range of motion means that the patient is moving their arm on their own versus a therapist or some other device moving their arm. And so that varies based on the tear, but typically speaking, we're restricting active range of motion between 6 to 8 weeks after surgery, especially with regards to motions that would compromise the integrity of the rotator cuff repair.
Can I expect to have a full recovery following surgery?
The question was, can I expect to have a full recovery after rotator cuff surgery? And I would say an honest answer that most people would say is that they can expect to have a full recovery for a healed rotator cuff surgery, but that full recovery can take upwards of a year. 6 months is where the vast majority of the functional gains are going to occur. But before they get all the kinks out of there, I'd say it's up to a year. But yes, that's always the intention and always the goal, with the qualifiers being the size of the tear, the age of the patient, and the quality of the tissue.
Will I need physical therapy after surgery? And if so, roughly how long will I need it?
So the question was, will I need physical therapy after surgery? And if so, how long will I need it? And the answer is, for the vast majority of patients, I do order physical therapy. There are some studies showing that self-directed home therapy programs with the patient doing it on their own can be very successful. And for the right patient who's appropriately motivated, that's a task that I've done many times. But for the majority of patients, they're doing physical therapy. For the standard rotator cuff that I do, most of them are starting 4 weeks out after surgery when there's been a chance for healing to occur. And typically they're doing therapy anywhere from 4 to 8 weeks after that time period.
We had 2 more questions roll in. One of them is, can you have a torn rotator cuff and a torn labrum at the same time?
So the question was, can you have a torn rotator cuff and a torn labrum at the same time? Unfortunately, that answer is yes. It's typically, to qualify what type of labral tear you have, most of them are more of a degenerative quality when they're associated with rotator cuff tears, and don't need to be fixed concomitantly. Fixing labral tears and rotator cuff tears have been found to be associated with an increased risk of developing stiffness after surgery, something called frozen shoulder. So it's rarely, but sometimes those instances do occur, especially with traumatic injuries.
Someone asked, I may have missed this, but how would you determine if it's a frozen shoulder or a rotator cuff tear?
So the biggest thing we do in the office, the question was, how do you determine the difference between a frozen shoulder and a rotator cuff tear? And it's simply an examination by me to look and evaluate your passive range of motion. And what that means is, can I rotate your arm out? And classically speaking, if you can't rotate more than 30 degrees passively, meaning when I rotate your arm out, especially if there's significant asymmetry compared to the other arm, that means you have a frozen shoulder. A rotator cuff tear, it hurts and you may have limited active range of motion for you to move it, but I can passively move your arm. So it's a clinical examination done in the office.
If I feel pain, popping, and grinding when rotating my shoulder, as well as it starting to feel like it's slipping in and out, could that be a torn rotator cuff?
So the question is, if I feel pain, popping, and grinding, and feeling like my shoulder is slipping out of place, could that be a rotator cuff? And the answer is yes, but those aren't always classical symptoms. Those are symptoms that we associate more with issues related to the labrum or to the capsule. But again, as we said before, the rotator cuff is a dynamic stabilizer of the shoulder, and rotator cuff tears can cause a lot of similar complaints, typically in an older age group.
And last question is, are there different types of tears?
So the last question was, are there different types of tears? And most definitely. As orthopedic surgeons, we give a lot of qualifiers and quantifiers to the type of rotator cuff tear, the shape of it, how many of the tendons that are involved. Each of them have certain characteristics of both healing potential and the type of repair required. And so when we do a rotator cuff repair, we're taking into account the size of the tear and the characteristics of them, but largely speaking, it has to do with what tendon is involved and the degree of retraction. Well, thank you very much for being here for my first Facebook Live. And again, I just want to say thank you to both Art and Chris for helping me out with this. At Tidewater Orthopedics, we're trying our best to provide you good quality orthopedic care, and have a wonderful night.